Hello, everybody. Welcome back. I am Amira, Minister of Justice and Witness for Clackamas United Church of Christ and community activists. I have two wonderful humans with me today. We have Julie and Galli. I would love to introduce them. I met with y'all last week about your organization. Tell me again, what does the H3S stand for? Whichever one of you want to answer.
Yeah, I'll take it. So H3S stands for Health, Housing, and Human Services. So we're known as Clackamas H3S, or Clackamas Health, Housing, and Human Services. And basically, in a nutshell, what Clackamas H3S is an entity of a significant amount of supports that we offer to our community. So we have about 700 employees in H3S, and we do a variety of things, but all of those things support our community in one way or another. So things like offering behavioral health services or primary care physical health services, substance use treatment, peer support, energy assistance, veteran services, workforce rehabilitation, social services, intellectual and developmental disability supports, crisis supports, wraparound services, you name it. I mean, the list goes on and on and on. We have a great group of folks that does really important work to support the members of Clackamas County.
Awesome, awesome. And what we met for was, everyone knows May is Mental Health Awareness, and we received an email from y'all asking if we could collaborate on doing a project for folks in the community. And so we talked about how the statistics of older adults that are dying at suicide at a higher rate. Can you go into that? I was quite shocked.
Yeah.
To hear about that.
I think that, you know, in the world that we live in a pretty ageist world. And so what ends up happening is that when our young people die from suicide, and young people for this conversation is defined as 10 to 24, although I wish I was in the young person category. I'm not. 10 to 24 is the definition of young people. When we hear about a young person dying from suicide, our community really rallies, it comes together. Sometimes there's a lot of media attention. And although our young people are dying and one life lost is way too many, who is dying more so than anyone else and who we don't hear about are our middle-aged, primarily men, and primarily white men. When I say middle-aged, 45 and up. So our 45-year-old white men are dying more so than any other population in our community. It's a significant amount of the deaths from suicide that occur, not our young people. And again, don't get me wrong, our young people are dying, and any death across the lifespan is tragic and one too many. But we don't hear about the 50-year-old. We don't hear about the 60-year-old. And those people, what we know is that for every single death from suicide, hundreds, over 100 people, about 150 people are impacted by that death. There's a huge ripple effect that occurs. And so whether it's a 60-year-old, man who maybe is a father, a grandfather, a partner, a spouse, a member of a congregation, a neighbor, you name it, or a 16-year-old young girl, the ripple effect for any of those deaths is significant. So we have to treat all of those deaths the same and get people support and make sure that we as a community are ready to be on the lookout for signs and symptoms of people who might be struggling so we can stop those suicides.
Right. And for your program, when they come in to do behavioral health, you guys ask the question,
Yes.
have you experienced suicidal thoughts? Is that?
Yeah.
Okay.
Yeah.
And then
so at all of our clinics, all of our behavioral health or primary care or crisis urgent walk-in centers, that question is asked of every individual who walks in. And that is that's a relatively new thing over the past many years. That did not used to happen, 10 years ago. And our commitment in Clackamas County H3S is to be intentional about the work of suicide prevention. And that's the difference, is that we are being intentional about catching people who might be struggling. And if you don't ask, you don't know. And so we're asking because we want to know.
Yes, that's awesome. Julie, what role do you play in this?
Sure. So I work in one section of H3S called health centers. That is where our clinics are. So our outpatient behavioral health and primary care clinics, as well as work in hand with our crisis clinic. And I am the zero suicide coordinator for all of the staff in those clinics to do the work of intentional screening for suicide fatality, and also setting up workflows and trainings for our staff to do this work every day.
Wow.
Yeah.
That seems like a really big job, but it seems amazing too. Like, wow.
Yeah, it's been wonderful. We've been doing it about 3.5 years now altogether with training and getting the workflows going, and it's been an amazing project.
Wow. That's great. And the pathway, so once someone says, yes, I am having these thoughts, they're put in what you guys call the pathway, which is basically a process to get them where they need to be in a healthy frame. And if there's any obstacles in the way, whether it be addiction or abuse, any type of anything, you guys assist in whatever that is. Is there anything else that I'm missing in that piece that you want to elaborate on?
I mean, I think the only thing that I would say, and Julie knows more about this, but the only thing that I would add is that when we talk about a pathway, we talk about when someone shares that they're suicidal, it's an amazing way for us to wrap supports around that individual. And just like if someone came to one of our clinics and was diagnosed with diabetes or diagnosed with asthma, or diagnosed with maybe anxiety, that person's going to be put on a pathway or a treatment plan or a plan of action or whatever you want to call it. There's going to be some intentional plan wrapped around that person to make sure that any barriers to caring for their diabetes, for caring for their asthma, their anxiety, or their suicidality, any barriers are mitigated. And Julie can talk more about, who along that pathway are helping our individuals and how amazing that is.
Yeah. So I also like to share too about pathways is they're very individualized. We have a standard process that we say these are the resources available within our, amazing work that we do, such as safety planning with clients, doing outreach calls, doing community outreach, working with them individually. But at any time, an individual can adjust their treatment plan for what's appropriate for them or who they want to share their story with. And we want to honor that privacy and respect their needs. But our pathway pretty much looks at every person that this individual will touch during their treatment with us, whether it be their primary care physician or the person who's scheduling an appointment on the phone. They will know that this person needs extra support and care if needed. So if somebody cancels an appointment, we'll call them back and make sure that they don't have any barriers to care. If somebody comes into primary care because they stubbed their toe, we're going to talk about their suicidality and making sure that they're safe and they have the resources they need. And on top of that, we have a team of suicide prevention specialists that work with us. There's 2 care coordinators or case managers and 1 peer wellness specialist that supports our clients only on a pathway. And that is what they do 100% of their time, is focus with these clients who've identified they need this additional support and help them in whatever resources that they need, whether it be food insecurity to housing, to help with paperwork, whatever it is to make their challenges less of a challenge and be more supportive to making them grow and thrive.
Wow, that's amazing. So what if somebody isn't, what if somebody is just someone off the street that hears about your program and they're not already in it? How does that work?
Yeah, so I'll kind of answer that one. So pretty much becoming a new patient with us, whether it be in our outpatient behavioral health clinic, it's called an intake. You come in and get an assessment, and to start and ask for treatment with us, that's when you would be identified as receiving services and be screened and placed on a pathway. In primary care, it's kind of a similar process. Anytime you come in for a primary care established patient, or even some of our, I don't want to say right now, I know COVID is a big deal, like those shots and stuff, vaccines are not getting screened at the high level of rate. But if you come in for any of our other services or established with us, one of the things you do at every one of your appointment is a screening for suicide.
Okay. Okay.
Yeah. So pretty much contact our clinics and come on in.
Okay, perfect. Is there a, with the pathway, I wanted to say like more of a, what you're looking for, like what we talked about for our congregation to help out in this portion of it. Can you explain how our community would be helping as far as writing the letters and things like that to individuals? How does that start? How does that happen?
Mhm. So I'll talk logistics, just kind of base, and then I'll let Galli go into the details of our caring contact concept. But pretty much once you're placed on a pathway, one of the things that we do for people is do what's called caring contacts, which is an outreach, non-demand notification, whether it be a letter, a text, a card, something along those lines that come to our individuals that are on a pathway with us, that just let them know that we're here for them, that we hope all's going well. And what we're looking for community support on is people who are on a pathway that are willing to accept additional resources and have their information shared, such as name and address, to help send these, points of caring contacts out, so more people are talking to the people and they're building, more support around them.
That's awesome.
And I will add that, so that, the caring contact idea, or caring letters, as some people refer them to, is, is not something that we came up with, and it's something that actually developed back in the 1970s. And I believe it started around people here at home sending letters to soldiers who were fighting in the war. And one of the things that's really important is this whole non-demand piece. And people often say, well, why does it have to be non-demand? And so the whole premise of these caring contacts is to foster connection and hope. And so by sending a message on a postcard that says, I'm so glad you're here, I hope you have a great day, Galli, that does a couple things. Like getting something, a random something, a text, a postcard, a letter, getting something like that coming to me feels really good, because no one's asking anything of me. I don't have to return the message. I don't have to think about a response. I don't have to find a stamp and put it on, I don't have to do anything. It warms my heart and it makes me feel seen. And so caring connection, or caring contacts, are all about fostering hope and fostering connection with another human being. You don't have to know that human being, but the letters, there's actual research that has been done that caring contacts that are done within a year's period of time actually reduce people's sense of isolation, and they reduce suicidality.
Yeah.
So again, it's such a simple, very cost-effective intervention that goes such a long ways.
Right. And so if people were to do this, do you guys supply like the stamps and the envelopes and all of that, or
we will supply stamps and the postcards and the envelopes that the postcards go in. We will supply all the things. And also, that we have postcards that we use, but my guess is that there's people out there in the community that might be able to come up with even something better, as far as a cool piece of art or a cool saying. We use something, but I would imagine there's some creative minds out there that could create some other messages of hope and connection, or art that fosters that. Would certainly consider wanting to use.
I know lots of artists.
I bet you do.
That's awesome. So I just want to touch on the one sentence I think you had said when I was meeting with you about the non-demanding would be excuse me, I haven't seen you in a while. Though that's something that most people wouldn't realize would be considered demanding. So that's why I just wanted to explain that little piece, because people might not understand.
So non-demanding are, I guess the best way to say them are phrases or statements that aren't really, they don't have a lot of feeling connected to them. So, a statement such as, I haven't seen you in a while, that comes from a place of oh, I'm really missing you, Amira, and I really wish we could see each other. And maybe, Amira, maybe you're struggling and you don't really feel like you want to see a lot of people right now. Maybe you feel like the pressure of seeing people right now is anxiety producing for you. And so you're just, you're just kind of hunkering down at home. So if I send a message to you saying, hey, I'm thinking about you, I'm so glad you're in my life, that feels a lot different than, hey, it's been a long time since we've seen each other. I really wish we could get together.
Yeah.
If you think about just kind of how that feels just in your own heart, those two things feel really different in how they settle in our brain and our hearts.
Definitely. Just having you say it out loud felt different in my.
Yeah. And so messages like, I'm so glad you're here. Your life is worth living. Your story is so important. It's sunny outside today. I hope you get a chance to get some vitamin D.
Yeah.
Anything along the lines. And you would be surprised at some of the simplest messages that get sent out to people. People report that they made their day, they made their week. Like they made a bad day turn into a good day. They made a bad month feel like, oh my God, someone actually sees me and like I'm valued. I'm a valued member of this world.
Yeah. Yeah. It's hard for people to separate if you have a friend with a mental health experience that can't handle a lot of interaction. It's hard for you not to take it personal and say like, I miss you, like I'm a positive person in your life. You want to talk to me. It's
Right.
hard to not do
What's
that.
what's wrong with me, right?
Mhm.
You should want to, but you're right, Amira, you hit it right on the head. It's like, we live in a world, especially right now with COVID and all of the things that are happening. It's like people are not doing well necessarily. And maybe somebody who has been historically pretty social, maybe is feeling anxious about being social right now for a lot of reasons. And maybe returning to normal, whatever that's going to look like, is also something that creates anxiety for people. So we have to follow people's lead and just let them know that we're there. And like even a card that says, I've got your back, don't forget it, I'm here if you need.
Yeah, that's great. I'm excited to participate. I would love to help out and do this. What's coming up next? What do you guys want anyone to know in closing about what you guys do?
I would say, so the biggest thing that is happening on the county level is that we actually are launching tomorrow, actually. So May 5th, right? Yeah, May 5th. We're launching our first suicide fatality review. And essentially what that is we're working really closely with the medical examiner, and we get permission from next of kin. So for people who have died from suicide across the lifespan, we get permission from their next of kin to essentially take a really close look at all of the systems and agencies and organizations and supports that may have interfaced with that person before they died. And the idea is for us to better understand in Clackamas County why our community members are dying, what's contributing, what might be contributing to their death. Are there gaps in our system, our large system? Are there gaps in our system that through this process we might identify, and then we can close those gaps so people are no longer falling through them and no longer dying? Like, an example might be, maybe someone's going to the hospital and they get discharged from the hospital for mental health reasons, and there's no plan for them after discharge. They just get discharged and like, good luck. And it's like, well, that's not a very good plan. And we know that the risk of suicide is really high after someone is discharged from the emergency department for behavioral health reasons, or from like a psychiatric inpatient admission. We know the risk of suicide is really high after that time, which a lot of people don't know. And so that's a gap. If someone's discharging and they don't have a plan, that's a huge gap, and that might contribute to someone's death. So this is a big deal. It's and it'll help us tell a story about some of the reasons why our people are dying from suicide, and then the next step is that we're going to close those gaps up, and so people aren't dying through those gaps.
Wow, and this is in our county, right?
This is happening right here in Clackamas. Yeah, wow. I have to say that there's not that many. I don't know that there's any other fatality reviews in the state. So this is a pretty big deal. Out of the 36 counties, we got a lot of really good stuff going on here in Clackamas. We have a lot to be proud of.
Wow, that's amazing. Wow. I'm just like, okay, so the project that launches tomorrow, what is the name of that again?
It's called the Suicide Fatality Review. And again, it's, of course, as you can imagine, it's not open to the public because we're talking about confidential things, but it's a group of community members. So hospital systems, law enforcement, peer supports, mental health providers, public health workers, you name it. Those folks are going to come together after permission from next of kin to talk about how we might do it differently. Yeah.
Well, I appreciate both of you. I'm looking forward to working with you both in the future. If you guys need anything from me, I'm here 100%, and
So we're so looking forward to working with you, Amira, and the community. It's what we're doing is it's a pretty novel thing. We are a government agency, and as you all know, government agencies kind of trip over our own bureaucracy, and we kind of don't know what to do with ourselves at times. So when we reached out to you to see if your community would want to partner with us in this really important but yet simple way of connecting with our community, and you said yes, it was like, oh my gosh, I felt like Julie and I both felt like we had won like the lottery or something. So we appreciate you all.
Cool. Awesome. I was like, I hope it's okay that I replied to that, because I was like, I'm on it. Oh,
yeah. Yes.
Awesome. Okay. One last question before we go. What is your superpower?
Julie, do you want to go first?
Sure. So I've been thinking about this question, and I think what I like to say is that my superpower is finding laughter in the little things in life. Even when there's a rough day, you just have to laugh at the littlest things to make that day better. So say that's my superpower.
I like that.
And I think my superpower is having an overabundance of energy. I realize that I'm kind of slowing down. I feel like I'm getting more tired in this world of ours. Life is hard at times, and parenting is hard, and all the things are hard. And so sometimes I just feel like, I'm so tired. I wish that I had energy to do the things. And so my superhero power for right now would be, I wish that I had an overabundance of energy so I could do all the things that I wanted to do for myself and for other people.
Yeah. One step at a time.
Exactly. One step at a time.
Awesome. Thank you both so much. And
Thank you.
I look forward to our work together.
Great.
Us as well.
Yes.